Presenting before you a case of 29-year-old female patient, Mrs. XYZ, who studied up to 10th standard. She's a homemaker who is hailing from Suratkal. Her husband's name is Mr. XYZ. He is 34 years old. He studied up to 8th standard and he is a shop owner by occupation. Their socio-economic status, according to modified BG Prasad classification, is class 2. Her obstetric score is Gravida 2, Para 1, Living 1. Her last menstrual period was on 8th February 2021. Her expected date of delivery is 15th November 2021. Her gestational age is 37 weeks 3 days. Blood group is O positive. She was admitted on 24th October 21 and examined on 26th. Chief complaint: the patient presents with pain abdomen since 3 days, white discharge per vagina since 1 day. History of present illness: pain in the lower abdomen since 3 days, which was insidious in onset, progressive in nature and severity. Maximum intensity felt on day 3. It's a dull aching pain which radiates to the back and flank, not associated with pallor, sweating, vomiting, palpitations, or fever. There was a watery off-white discharge since 1 day. It's non-foul swelling, scanty in quantity. It's not associated with itching or dysuria, and there was only one episode. History of present pregnancy. She conceived spontaneously. The pregnancy was diagnosed by UPT at home after 40 days of amenorrhea and confirmed at the hospital. There's a history of nausea and vomiting with 2 to 3 episodes per day, which subsided after 6 weeks with tablets. There's a history of folic acid intake started immediately after pregnancy was confirmed. There's no history of increased frequency of micturition, burning micturition. There's no history of fever with rash. There's no history of bleeding, TB, or white discharge. No history of exposure to radiation or drug intake. Dating scan was done at 2 months of gestation and was told to be normal. Second trimester, quickening felt at 16 weeks. She received 2 doses of TD, iron and calcium tablets taken from 20 weeks of gestation. There's no history of fetal edema, epigastric pain, blurring of vision, headache, or vomiting. There's no history of excessive weight gain, excessive thirst or hunger, increased frequency of micturition, or fatigability. There's no history of leaking or bleeding TB. Scan done at 20 weeks and it was told to be normal. Third trimester, she continued to perceive fetal movements. Iron and calcium tablets were taken. Growth scan was done at 30 weeks and reported to be normal. There's no history of swelling of limbs, no history of bleeding or leaking TB, no history of pain abdomen, no history of headache, blurring of vision, epigastric pain, vomiting. There's no history of breathlessness, dry cough, sore throat, or fever. Obstetric history: spontaneously conceived at the age of 26 years. Antenatal events: all the events were uneventful. Perinatal details: institutional delivery by emergency C-section at term, done 3 years ago. Indication being failed induction. Spinal anesthesia was given. Outcome: 3-year-old baby boy, alive, weighing 2.6 kg at birth, cried immediately after birth on August 2018. Breastfed for 6 months. There was no NICU admission. The baby is currently healthy, immunized, up to date, and doing well. Postnatal events: uneventful. Suture removed on 6th day after the surgery. Urine catheter removed after 2 days of surgery. There's no history of blood transfusion. She was discharged on 7th day post-operative day. Menstrual history: she attained menarche at 14 years of age. She has had regular 28 to 30 days cycle with 7 days flow. She changes 3 pads per day. There's no passage of clots, no dysmenorrhea. Her LMP is on 8th February 2021. Her EDD is 15th November 2021. Marital history: married life is 4 years. It's a non-consanguineous marriage. Past history: She is not a known case of diabetes mellitus, hypertension, thyroid disorder, TB, asthma, or epilepsy. There's no history of surgery other than cesarean deliveries. ANC visits monthly once from 8 weeks till 28 weeks. 3 visits in third trimester, total of 8 visits. Family history. There's no history of hypertension, diabetes, TB, bleeding disorders, twinning, or hereditary conditions in the family. Personal history. She consumes mixed diet. Appetite is normal. Sleep is adequate. Bowel and bladder habits are regular. There's no history of substance abuse. No known drug allergies. Contraceptives not used.
Just wait, Thanusha, let's go back. Go to the first slide. Okay. The second one. Okay. So, very few things about the basics, most important things where we don't want to do any kind of mistakes in any obstetric case. As I've already told in one of the classes previously, obstetric case is the most important case for you people, undergraduates. Okay, gynae, not much happens in gynae actually. We just see whether you're able to identify and not give wrong treatment rather than even giving correct treatment. But obstetrics is extremely important. Okay, so the first thing is the obstetric score. Okay. So obstetric score, most of you will get it right, but when you do a mistake, it looks really bad. Like if anybody tells me, you know, she's grabbed a 2, para 2, like one, I get really irritated. Okay. So in the similar way, there are many people who will get irritated because it's very, the most basic thing in obstetrics. So Thanusha, if there is a patient who's delivered twin gestation in the last pregnancy, both the babies are alive and healthy now. This is second time pregnant now. What will be the obstetric score?
Will be gravida 2, para 1, living 2.
Gravida 2, para 1, living 2. Good. So please, one important point here is parity and gravidity can never be same. Okay. Gravida has to be one more than para. Okay. Gravida includes the present pregnancy and parity excludes the present pregnancy. Okay. And parity is number of previous pregnancies which have crossed the period of viability, not the number of fetuses which have crossed the period of viability. Okay, whether it is twins, triplets, quintuplets, whatever plets, it is only one pregnancy which gave rise to those babies. So it will be always counted as P1 as you rightly told. Okay, that is number one problem in obstetric score. Most of you do the mistake over there when you consider twins as 2 para. Okay, that is one important thing. Then in the LMP EDD section, it's always good to mention about the previous cycles before you comment about EDD itself. Okay, once you tell her last menstrual period, you should comment that her previous cycles being regular, her EDD falls and so on. So, okay, that's because if the cycles are extremely irregular, this EDD does not hold good at all. There is no point calculating EDD also. For example, if this patient's cycles were once in 2 to 3 months, then you just present it as her last menstrual period was on 8th of February 2021. And previous cycles were once in 2 to 3 months. So her dates are not reliable for dating this pregnancy. Okay, so that's how we'll present if it is very, very irregular. If there is slight irregularity, then we can go ahead and we can, give a corrected EDD. Okay, that is why, like for example, patient gets her cycles once in 40 to 45 days. Okay, it is not very irregular, right? It is slightly irregular. So we'll take how much of extra days were there and add on those many days. No, for example, 28 days is what we consider as regular cycles. If the patient is getting once in 40 to 45 days or 35 to 40 days, take the longest cycle and see how many more extra days are there than 28. For example, her longest cycle is 40 days, then it is 12 days extra, right? So add those 12 days to the EDD. Add. Her EDD will get postponed if there are delayed cycles, because all of you know very well that if there is an irregular cycle, what is constant is which part of the menstrual cycle is constant?
The
follicular phase or luteal phase?
The luteal phase.
Luteal phase is constant because corpus luteum has a fixed lifespan of around 14 days. Okay. The follicular stage is the one which actually keeps varying. If she's got a delayed cycle of 40-45 days, that means she had a longer follicular phase. Okay. So that means she is conceived late, so her EDD will get postponed. Is it clear? Okay. So that is why it's important to comment about the cycles in between last menstrual period and EDD. Okay, and one more thing is, whenever the last menstrual period comes in the last week of the month, mistakes tend to happen, which will lead to an error of almost 4 weeks. For example, if the LMP was on 25th of February, okay, you should not write off automatically as add 7 days to 25, then add 9 months to February and give it as some 3rd of November or something, which will lead to a gross error. You should remember to jump a month. It's going to be more than 9 months over there for you if you're just adding things like that. If you do it properly, then it's easy. Okay, so add 7 days to the date first, then you add 9 months to that particular date always. Okay, so whenever LMP comes in the last week of the month, be a little careful about this particular error in LMP. Okay, go to the next slide. So the chief complaints, fine, this is fine, but go to history of presenting illness. Okay, see, history of presenting illness, what's the most important thing in this which is missing? Thanusha, if the patient has got pain in the lower abdomen, I would like to know one thing first, especially if she's a term pregnant lady comes with pain in the abdomen, what will be your first, concern?
She might be going into labor.
Labor, okay. So describe labor pains.
Labor pains, they are painful, regular, and they increase in frequency, duration, and intensity. Okay. May be associated with passage of show.
You again missed that keyword. Labor pains are intermittent. Thankfully, God has been kind enough not to give continuous pain to a laboring woman. Okay, it's intense pain. Okay, out of a 10-minute duration, if you take, the lady is going to have maximum pain for 2.5-3 minutes. The rest 7 minutes is going to be pain-free. Understood? So the intermittent term should come. Okay, whether it is continuous pain or intermittent pain. That's one very important distinguishing factor between labor pains and other types of pains. Okay, you kept only in your mind to rule out false labor pains and true labor pain, but you should also think of labor pains and other causes of pain. Can you tell me some other conditions which can lead to lower abdominal pain in the pregnant woman?
If there's a chronic pelvic inflammation or any
pregnant women. Not that they can't have PID, but it is not that common. So think of some other common things.
Ascending infection.
Others can participate in the discussion if you know the answer, or put in the chat box. So basically, please remember that in the pelvis we have other organs too. Okay, there's some answers coming up in the chat box. Acute appendicitis and abruption. Okay, abruption is something you should never forget. Okay, irrespective whether the patient is hypertensive or not, abruption should be kept in the mind whenever patient comes with pain, especially in a late pregnancy. Okay, so that is one thing. Other than that, I was telling you that there are some other organs other than the uterus. There are some other organs. Priya, this is extremely rare. Okay, this red degeneration of fibroid, torsion ovary, we should keep them in the mind. They're all causes of acute pain abdomen. Okay, in pregnant women. Yeah, this is what I wanted to see. UTI. Okay, there is a urinary bladder over there. Shankar Narayanan, good. Okay, so cystitis is extremely common in pregnant women. Okay, so that can lead to significant lower abdominal discomfort, which is the other organ which is there other than uterus. One is bladder, other one is
bowel behind.
Posteriorly, we have rectosigmoid, right? So if they have colitis, again they'll have a lot of lower abdominal pain. Okay, so you have to keep these things also in mind, other than the obstetric causes, what they already mentioned, like abruption. First of all, true labor pains, then false labor pains, okay, and then abruption, then all these, rare complications which can happen, like torsion ovarian, red degeneration of fibroid, okay, or, acute appendicitis, any surgical emergencies, whatever, okay. So you'll keep all this in mind, but don't forget the most common thing like cystitis and colitis, okay. And sometimes even constipation. Constipation will lead to significant colicky kind of pain for them. Okay, so you have to make sure that you ask her whether it is related to any kind of bowel movement. Okay. So that's about the pain. I think there is nothing much in this. We'll go to the previous LSCS proper. Go to your, about this discharge, is only one episode she's had, so I'm not going to bother much about it. We'll ignore it. Go to the next slide. Next slide. I mean, history of presenting illness is pretty okay. You did a pretty decent job. So I'm not going to stress much on it. Go to the past obstetric history. Yeah, that is what is most important for us, right? So patient has conceived spontaneously at the age of 26 years. See, when you present like this, I will have to sit and calculate how long she's been married, what's her age now, how many months, years it's been. It should not be like that. The most important point is what is inter-delivery interval. Okay, for a previous LSCS patient, there are certain things. See, the whole idea is to decide whether we can give her a trial of scar or should we go for elective cesarean delivery. Okay, so all these points will help us to come to that particular decision. Okay, there are a lot of hospitals who will directly do cesarean section for all previous LSCS, but you know that the dictum, one cesarean is not always a cesarean. Okay, there is a scope for trial of scar. Okay, it's very important to remember that, because what happens is already our cesarean section rates are plummeting very high, and if we do not give TOLAC also, then we'll end up having almost 50%, 60% cesarean section rates. Okay, so it's very important to practice all these obstetric skills like trial of scar, pre-deliveries, to decrease the incidence of cesarean sections for us. Okay, any day cesarean section is an operative delivery, it is not a normal delivery, right? So the whole idea is to decide whether we're going to give trial of scar or we are going to do elective cesarean delivery, because the risk is too high. That's the whole thing. So number one is, what is the inter-delivery interval? So spontaneously conceived at 26 years, you told me 29, right? She's 29 right now. So it is 3 years back. I don't want the conception year. I want the delivery. It's okay. This delivery, when you say obstetric history, you will say the previous delivery was so many years back. Okay. So what's the significance there? What's the cutoff for us to, which is safe for trial of scar?
Minimum is 18 months, ma'am.
18 months or 1.5 year inter-delivery interval. Please remember, she's at term now, so she's going to deliver any moment now. So if it is 1.5 years since her last delivery, then we can allow her a trial of scar. Okay, that is because there are a lot of studies which have used MRI, serial MRI, to see the scar healing, the healing of the uterine scar, and they have come to a conclusion that yes, the scar heals properly by 18 months. Okay, so that's why it's very important for us to at least have an 18 months delivery, inter-delivery interval. Okay, so you will start it as she conceived spontaneously at the age of 26 years, that is 3 years back. Okay, yes, but I don't really want when she conceived. I told you I want when she delivered. Okay, and then you should also say where was she booked and immunized. Was she unbooked or booked? That should come. Okay, antenatal events, you have written all the events uneventful. It's not like that. What do you mean by all the events uneventful? Okay, it's like an oxymoron. Okay, so you should mention where was she booked and immunized, and then how was her antenatal period. That's all. Okay, and then see this perinatal details. It's better to go like a story. What exactly happened? Why was she being induced? There is no comment about why was she being induced over here. Understood? Okay, was it for some PROM or past dates or PIH or whatever, like, we have no idea why she was being induced, right? So it's better to go like a story, at term or 2 days after her EDD, patient did not go into labor. So she went to a hospital, their ultrasound was done and she was told to have less LICA, and then she was induced. And patients generally will know what was used for induction of labor also. Basically cervical ripening. When we say induction of labor, it's going to be cervical ripening followed by induction of labor. So patients might be able to tell you, they gave me some tablets or they gave me some tube, they put some tube in my internal organs or whatever. Okay, so that particular detail should come over here, but that is because some indications itself are dangerous for us, that. Okay, so that will help us to decide whether we should allow trial of scar. Failed induction, I'm not worried much, but if this patient does not go into spontaneous labor and we need to induce her, we know that her chance of going for failed induction is high this time also. That's it. Okay, that's the only significance for us, but there are other indications which are much more dangerous for me. For example, she was in labor. Okay, she went in spontaneous labor or an induced labor, they'd induced, whatever it is, and it was a very prolonged labor, and then she was asked to bear down, they had given a cut in the perineum, all these things, and then they did section. Understood? So we know surely that it is a second stage CPD. Okay, so those kind of indications are not good for us. Okay, or at around 8 months of pregnancy, she had leaking PV. When she went, they told that baby's hand is already out. So we know it is transverse light, PPROM and hand prolapse, which is again a very dangerous condition to give trial of scar. So all these things will help us to decide when not to give cesarean section. I mean, when not to give trial of scar. Okay, so indication should be given due importance. It should better to come like a story. Okay, what exactly happened, how many hours she was there in her labor, and all those things should come. One thing you have to ask for any patient where cesarean section was done in after a significant amount of time in labor is, was she asked to bear down? Okay, because we'll obviously in an institute, we'll ask patients to bear down only when they're in second stage. Okay, so if she was asked to bear down and then cesarean section was done, she is not a candidate for total control. It is a second stage section and we don't give trial of scar. Okay, so that should come. Okay, then your outcome, this is fine, this is fine. Go to the next slide. So this postnatal events, suture removal. Why do I ask for all these things? What is most important for me here?
Like just to like if sutures usually are removed on day 5 and day 6, just to see if there was any wound infection or resuturing was done.
So basically, when we ask a question, Thanusha, we're basically making sure that we don't miss any history. You know that history taking is an art. Okay, the way you communicate with the patient is an art. You should let them tell stories, but you should also know when to cut them short without them realizing that they're being cut short. Okay, otherwise the stories will go on and on and on. Okay, but you should know how to get that particular information from her. For example, the moment you ask her about sutures, she may come out with the history that they removed the sutures, but then the whole wound gaped, and then they had to keep in the hospital for some more days and clean. There was a lot of pus. All this history will come. That is why we have these leading questions, which may lead us to some important information in the post-op period. Okay, what else will you ask in the post-op period? Some negative history also is extremely important over here.
Like any fever or like infection, and then even the urinary catheter. Usually it's kept for 1 day, but if it's like kept up for a week, then there must have been a urinary damage, like urine bladder.
Okay.
And then yeah, and she was discharged on 7th day. She said there was no resuturing or wound infection.
Okay. See, this is fever history alone probably is not very important. There are a lot of causes for fever following cesarean section. I'll be more interested to know whether she had fever with foul-smelling lochia, which is indicative of endometritis. So that foul-smelling lochia is the keyword for us. Okay. So you should ask the patient, did she have any discharge from the wound? That is one thing. If it is just simple discharge from the wound, she did not require secondary suturing and all this stuff, I don't really care much about it. It means it is the skin pathogens which have gone in and causing havoc over there. But if it is something which required secondary suturing, complete dehiscence of the wound and all this stuff, it indicates a deeper infection, which would have been there during cesarean section, and we can assume that same kind of infection would have affected the uterine scar also to make it weak. Okay, so this is an important distinction. When the infection is superficial, we don't really mind giving a trial of scar. But if the infection is deeper, it means that even the internal structures can be infected. Okay, so that is about the sutures. Then about fever with foul-smelling lochia is very important information, because it obviously indicates that there is endometritis and the scar will be surely weaker in that scenario. Okay, so these two things are very important. And as you rightly mentioned, if there is history of prolonged catheterization, what will you think of? Only bladder injury or something else?
Usually like bladder injury during
see, bladder injury is not that common, thankfully. Okay, even if a lot of residents do the cesarean section, bladder injuries are thankfully not that common. What's more important is that if the catheter has been kept for 7 days, 5 days plus, anything more than 5 days or more, okay, yeah, somebody is answered over there. Basically, it is probably an early obstructed labor. To prevent an obstetric fistula, VVF, they keep a catheter. Okay. So whenever it is, I told you, second stage CPD or obstructed labor, we don't give trial of scar. So this is one of the indicators to us. See, if somebody comes in to you with a discharge summary, you are way better off to decide about the trial of scar, because all information is available for you. But how many women will get a discharge summary to you? That's a problem. Okay, if the cesarean section was done in your own institute, probably you'll have the records in the HIS, Hospital Information System. Okay, you can collect the case sheet from there and check out and all this stuff. But most of the time, especially in our center, we deal with women where primary cesarean is done elsewhere, and they come with no note in their hand, no discharge summary, no note of what happened in the previous pregnancy. So we entirely depend on different indicators of different problems over there. Blood transfusion, how is that important? Tell me.
Was she anemic previous, or does she have postpartum bleeding?
See, again, the relevance for this case point of view is like trial of scar point of view is, if the patient has had an unplanned blood transfusion, if she's anemic, should have been told that yes, you'll need blood. Please arrange blood. We have to give blood before we do cesarean section. Okay, but if it is an unplanned blood transfusion, it means she's had significant blood loss during delivery, operative delivery, cesarean section. Okay, that might have been because of angle extensions involving the uterine arteries. Whenever there is angle, uterine incision, the ends are called as angles. If there is angle extension involving the uterine vessels, it means that they would have ligated the uterines, which will again impair the blood supply to the scar and may make the scar weak. And the extension would have gone into any part. It might have gone into the upper segment also, or lower segment deeper also, whatever. We really don't have much idea. I told you we're using all these things as an indicator of some complication intra-op. Okay, so it's very important. One thing which is missing over here, one more thing you should ask over here is surely about contraception. Nowadays, you know that we have a habit of putting in a copper T. Post-cesarean, post-placental placement of copper T is extremely common. Okay, so moment you ask that, she may come out with some other important history. Yes, they had put in a copper T when you ask about contraception. And she might say the threads were missing, so when I went, they removed it with a lot of difficulty. Okay, again, which might indicate there's been a lot of meddling in the uterine cavity, which would have affected the scar for us. So all these things, maybe we assume too much, but it is very important not to have a complication. You know that rupture uterus can be catastrophic. We'll lose the baby. Okay, so we'll look at each and every point, and then we'll come to the conclusion of whether to give trial of scar or not. Okay, understood the importance of past obstetric history now. Right from your, go back 1 or 2 slides. Thanusha?
Yes.
No, obstetric history only. Okay. So right from the interdelivery interval, whether it is an emergency or elective cesarean section also, okay, term or preterm. One more important thing, this was done at term, so there is no headache for us. If it is done at preterm, again, we don't give trial of scar. Why we don't give trial of scar for previous preterm sections? The lower uterine segment wouldn't have been well formed. Okay, you know that lower uterine segment forms only towards the term. Okay, so when the lower uterine segment is not well formed, you know that the incision is going to be thicker, and whenever the incision, the uterine angles are thicker, what happens is it will have pockets of hematomas in between. Okay, so that will lead to problem. Again, it will lead to a weak scar. Okay, so preterm sections previously done, we don't give trial of scar. Okay, so all these points will help us. So many points, I told you so many till now. I hope you have remembered something at least. Okay, so indications I told you. For example, I told you CPD second stage. One more indication is like placenta previa, anterior placenta previa. They've done cesarean section. It might not have been covering the os. It might be just coming up to the os or whatever. But you know that your incision is going to be on the placental implantation site. You know that that area will be full of venous sinuses, and again the healing is going to be bothersome for us. We don't do trial of scar for that patient. So before you decide for trial of scar, we have to be extremely careful to look at all these things. Okay, is it clear to all of you? Go on. Let's move ahead. Leave all this. Go to the examination.
General physical examination. Patient is conscious, cooperative, and well-oriented in time, place, and person. He is well built and moderate. Her pre-pregnancy weight is 48. Her height is centimeters, and BMI is 18.46 kg per meter square. Her vitals, pulse is 70 beats per minute. Blood pressure is 110 by 80 millimeter of mercury, left arm in sitting position. Respiratory rate is 14 breaths per minute. Temperature is afebrile. There is mild pallor present. There is no icterus, cyanosis, clubbing, lymphadenopathy, or edema. Thyroid, breast, and spine examination appear normal. For abdomen examination, patient is supine with knee semiflex. On inspection,
Thanusha, for inspection, you have to have the legs extended. If you keep in this position for inspection, you will miss the scar completely. Okay, please remember, the position for inspection of the abdomen is fully extended legs. Okay, and the patient should be exposed from upper border of pubic symphysis to xiphisternum. Okay, and laterally the anterior iliac spines on either side. Okay, but cover her properly, exposing only this much. Okay, to make sure that you respect her privacy also. Always use a screen and all this stuff. And before you touch the patient, tell her what you're going to do. Make it a point to communicate with them and tell them. because they should not think that you're going to do an internal examination in the ward or something. You should tell them, I'm only going to do the abdominal examination. That's it. Okay. And you make sure that she's covered well. The rest of the area other than what I mentioned should be covered well. Her chest, the lower part of the upper thighs, everything, it should be properly covered. Okay. So the position for inspection is legs extended, and this position what you have mentioned over here is for palpation. Okay, go on.
On inspection, the abdomen is longitudinally distended, umbilicus is central and inverted, linea nigra striae gravidarum striae albicans are present. There is no visible pulsation, cyanosis or engorged vein. Hernial orifices are intact. A transverse curvilinear scar is seen above pubic symphysis, which is healed by primary intention.
Okay.
On palpation, position with the knee flexed, semi-flexed, abdomen exposed. Okay. There's no tenderness with relaxed uterus. Fundal height corresponds to 32 weeks. Symphysis fundal height measurement is 31 centimeters. Abdominal girth is 95 centimeters at the level of umbilicus. Obstetric grips, fundal grip, a broad, soft, irregular mass suggestive of breech. Right lateral grip, continuous curvilinear resistance which is suggestive of spine. Left lateral grip, multiple knob-like irregular structures suggestive of limb buds.
Okay.
And then first pelvic grip, a hard, globular, smooth, ballotable mass suggestive of fetal head. Second pelvic grip, fingers are not converging. There is no scar tenderness. The estimated fetal weight according to Johnson's formula is 2,945 grams. On auscultation, fetal heart sound heard at right spino-umbilical line.
Okay.
Other systems examination, CVS, S1, S2 heard, no murmurs. RS, normal vesicular breath sounds heard, no added murmurs. CNS, no focal neurological deficit. Summary. A 29-year-old Mrs. XYZ, who is a gravida 2, para 1, living 1. Her last menstrual period was on 8th February 2021. Her expected date of delivery is, she has a regular cycle and her expected date of delivery is 15th November 2021. Her gestational age is 37 weeks, 3 days. She presented with pain abdomen and white discharge per vagina. Also, she has a history of previous LSCS. She is a booked and immunized case with regular ANC. Examination revealed a single live term pregnant uterus with cephalic presentation.
Okay, fine. This is okay. But for the postgraduates, just go back to the summary, please. Okay, for the postgraduates, when you're telling about the also has a history of previous LSCS, don't mention it like an afterthought. It is very important history for us. Okay, and you should also mention patient is a post-cesarean pregnancy with no historical contraindication for trial of scar. Like by the history, we have not got any contraindication till now, right? Whatever we discussed, none of those things were present in this particular patient. So that should be mentioned. This is mainly for PGs, not for undergraduates. Okay. Otherwise, the history is almost the same thing for both undergraduates and postgraduates with this particular thing. The way you put it across is important. Like for undergraduates, we'll expect you to tell multiple knobby feelings felt, which are suggestive of limb buds and all this stuff. In PGs, we don't expect you to tell all those details. You can just say serial obstetric grips reveal a single live fetus and longitudinal like cephalic presentation with spine on the right side. Okay, with adequate amount of liquor and a good fetal heart sounds. That should be enough if it was PG. But for undergraduates, obviously all this is important. And in our center, at least, we'll ask them to demonstrate the grips for us actually. Okay. So people should know how to do obstetric palpation. It's extremely important. There should not be any confusion about the first grip. Go back to the first and second grips, man. See, there are some things in this. Then next slide. In the first pelvic grip and second pelvic grip, there is no contradiction here. But sometimes some students won't realize what they're telling. They will say ballotable mass. Okay, and then they will say head is engaged. Okay, so you are contradicting your own findings. How can you ballot a mass which is engaged already? Okay, so don't do such mistakes. They're basically common sense that moment you say ballotable, it means that head is above the level of pelvic brim. Otherwise, you won't be able to ballot it inside the pelvis. There is not so much space to ballot the head over there. Okay. And moment you say engaged head, you should make sure that second pelvic grip is telling fingers are diverging. Okay. So one more important thing in the second pelvic. What is missing here, Thanusha, in the second pelvic grip? She's a term patient. In a preterm, I might not bother much about it, but in a term patient, second pelvic grip also gives us the information about
the lie and presentation.
No. First, second pelvic grip.
Oh, the head, whether it's engaged or.
That you have told. Fingers, what do you mean by fingers not converging is actually wrong.
Oh.
Fingers should be converging here because it's a ballotable mass. Okay, yeah. Sakru Singh is mentioned over here. Whether what is the attitude of the head, whether it is flexed or extended head. Okay, how do you determine it? Do you have any idea, Thanusha? How do you make out whether the head is flexed or distended?
So you can feel the inciput and occiput. If they're at the same level, then it's deflect. If it's the occiput is at a higher level, then it's well flexed.
No.
Or if inciput
exactly ulta you're telling actually. When the occiput is at a lower level, it's a well flexed head. Yes. Okay. And how do you know which is occiput, which is inciput when you touch both the poles of the head? In second pelvic grip, you're coming from anterior superior iliac spine down like this. How do you know which is occiput, which is inciput?
Occiput,
common sense.
From the lateral grips, you can get to know the.
From the lateral grips, you will know which side is the spine. Okay. So whichever side is the spine is going to be occiput. Obviously, right? Spine, occiput. That's it. Okay. So that is how you will realize which is occiput, which is inciput. Okay. So you should comment about that also. Head is appearing flexed or deflexed or extended or whatever should come over here. Okay. About scar tenderness, tell me what do you mean by scar tenderness?
Scar, like on palpation, there'll be.
Which scar are you talking about? The abdominal scar or the uterine scar?
Here, the uterine scar, ma'am, you have to be palpated. So we get an idea. If it's like LSCS, then it'd be from the umbilicus to pubic symphysis, it'd be in the lower third. A transverse palpation is done. If it was a lower uterine scar.
See, most of the cesarean sections are lower segment cesarean sections. Okay, yes. The lower segment is going to be pretty much lower than the lower 1/3 of the abdomen. It's going to be somewhere behind the pubic symphysis, just behind the upper border pubic symphysis. So you have to palpate in that particular area. Okay, how exactly do we do it?
Transverse palpation in that, like
palpate that area. Okay, at that moment you should be looking at the patient's face. Okay, and try to distract her. Ask her about the first baby. How old is the first baby? Grimace, not grimace. No. Look at her face to look for any wincing. Okay, does she wince with pain? Okay, in spite of your distraction, that's very important. Otherwise, all women will be worried about the scar, and the moment you touch it, they'll wince. So it's very important to distract them with something which will interest them. You know that every mother will be interested to talk about her first baby. Okay, so ask her how old is the first baby, whether it's a boy or girl, whether it is walking, depending on whatever age she says. You keep on discussing something with her and keep looking at her. Only her hand should be palpating the lower part of it, just above the upper border pubic symphysis. You'll palpate that area, and then you will see whether she's having any scar tenderness. Okay, what do you, if she's having tenderness, what does it mean?
It indicates like whether scar dehiscence or scar rupture. It's a sign, ma'am.
It is one of the signs of scar dehiscence, not scar rupture. Rupture is too much extreme. We don't want to diagnose patient at rupture, right? There is no point. Nothing can be done once we diagnose rupture. So we should concentrate on diagnosing at a level where we can prevent further catastrophe. So that level for us is scar dehiscence. Okay, I will tell you what are the difference between these terms. Okay, so we assume that if there is scar tenderness, it means that it may be scar dehiscence. Okay, so what could be the other causes of tenderness in that particular area? Chat box. If there is scar tenderness,
scar tenderness.
Yeah, scar tenderness is there. That means scar tenderness is basically not abruption. Scar tenderness is basically, you are palpating that particular area, just behind the upper border pubic symphysis. Okay, so in that area, what all can be there? You know that there's going to be bladder. So it is cystitis again. Don't say UTI because UTI includes even pyelonephritis. If there is pyelonephritis, she won't have tenderness over there. So it should be specific. Your answer should be specific. So it's going to be cystitis. Okay. And other than that, what else can be there which can lead to tenderness? Infection, yeah, Shankaranarayanan, infection of the bladder in that area. Okay, generally we don't have any other infections. If there is chorioamnionitis, it's going to be tenderness all over the uterus, not only in that particular area. Okay. One more thing is, if there are dense vascular adhesions because of previous LSCS between the bladder, the uterus, the anterior-abdominal wall, all these areas, in that particular area, it is extremely common. When you do labor room postings, you would have seen that they'll be struggling with, the adhesions over there. Though if the adhesions are flimsy, they won't lead to any tenderness. But if they are dense and vascularized, then that area is going to be really tender. Okay, so keep in your mind these two things. That is why we don't take a single thing as indicator of scar disease. Okay, we'll discuss about how to monitor and all this stuff. So this lady, this much information is okay for undergraduate, but postgraduates obviously will have to do a pelvic examination, see the Bishop score, see the pelvic adequacy for this particular baby before you comment about what is your plan of action. Okay, undergraduates are not expected to do all these things. With this much of info, we'll only give a scenario. Okay, you have done a PV, her Bishop score is 2 and a pelvis is adequate. How do you go forward? Okay, she's only 37 weeks, right? We still have a long way to go yet. Okay, we don't need to intervene unnecessarily. Because in a patient with post-cesarean pregnancy, it's always better to wait for her to go into spontaneous labor. Spontaneous onset of labor is always better than induced labor in this condition. Okay, because induction of labor is known to cause a lot of issues here. Okay, so we don't want to induce labor. So obviously, if everything else is fine, the amount of liquor is good, patient is feeling good fetal movements, there is no other issue like diabetes, hypertension, all those problems, then we can easily wait up to at least an EDD. Okay, we sometimes wait beyond an EDD also if everything is fine. But at least till an EDD, I think everybody will. 3 weeks, we'll wait for her to go into spontaneous labor. If she's labor, at that time, we'll assess her again and see what can be done. For example, your institute doesn't believe in going beyond her EDD in post-cesarean. So at 40 weeks, she's not going into labor. What will you do? Thanusha.
Yes, ma'am, I can hear you. There's some lag.
40 weeks is not going into labor. What do you do? Is my signal
for
poor
her,
or your
because
signal?
There's no.
What is it? Who's there? Priya?
Oh, wait.
Simran? Shankaranarayanan?
I can hear you clearly now, ma'am.
Okay, fine, go on. I'm having some disturbance here, so I was wondering whose signal is poor. Okay, tell me.
So, because there's no absolute contraindication for trial of labor after C-section, like wait for spontaneous, if not induce labor.
We have waited for spontaneous labor till 40 weeks. She's not gone into spontaneous labor. Okay, so what do you do now? You want to go ahead and induce labor or do direct cesarean section?
If we induce labor, then the chances of successful trial of labor after C-section will be low. Like if all the facilities are present, like 24 hours OT facility, everyone, then we can go for induction of labor. If there's no facility and she hasn't given a consent, then elective C-section.
See, the discussion is assuming that patient wants trial of scar. Okay, otherwise there is no discussion at all. First thing is the prerequisite is patient should be willing. It has to be an informed consent. Informed consent is explaining the risks and benefits of a TOLAC and a successful VBAC later on. Okay, TOLAC is trial of trial of labor after a cesarean, and VBAC is vaginal birth after cesarean. A TOLAC should lead to a VBAC. Okay, there's a short forms we're using, so I just clarified that once to you people. So assuming the patient has given an informed consent, what will you inform her, by the way? What is the risk of scar rupture in a previous lower segment cesarean scar like this, where there is no other high risk factor? What's the risk? 1 in
200 pregnancies, ma'am.
Okay, 1 in 200, that is 0.5%. Okay, that's correct. Okay, so you should tell her that 1 out of 200 women only will have some problem with the scar, because everything else looks okay for us by our history and examination. That is how we will counsel the mother. Don't tell her. Moment you tell her that your scar may rupture without quoting the numbers and the probability of what is her risk of having that particular complication, no woman will give the consent for a trial of scar. Who wants to have a rupture uterus now? Okay, it's very scary, right? Your uterus is going to rupture. For a lay person to listen to that is going to be really scary. So you should tell her that the chance of the previous scar giving way is so less. It is less than 1%. Okay, they might not understand, so it's better to tell the way you told, 1 in 200. Okay, so that is how you will convince. You should also tell her that if you deliver normally, it is good for you. Otherwise, you should mention to her that one more cesarean section can be associated with all the risks of a repeat surgery. The wound may give way because it is second operation for you, and all those things should be told to her. See, it all depends upon how much you want to give the trial of scar. If you are moving towards, cesarean section, you'll counsel her in that. It's very simple. Okay, so counseling is very important for these particular women. They should only offer an informed consent. You will worry about other factors over here. Once she gives informed consent, you will assess by history, does she have any contraindication? By examination, is there any contraindication? Then only you will worry. Okay, about induction of labor in post-cesarean pregnancies. What's most important is that we do not use prostaglandin E1, or otherwise called as misoprostol. It is absolutely contraindicated in these women. Okay, for cervical ripening or for induction of labor, PGE1 is not used at all, misoprostol. Okay, we generally prefer non-pharmacological methods of cervical ripening. Tell me what can be used if it is non-pharmacological method of cervical ripening?
Artificial rupture membrane, then
Foley's catheter. Okay, Foley's ripening. Artificial rupture of membranes is only after Bishop's becomes favorable, right? We can't do it without having a favorable Bishop. So first thing is to ripen the cervix. We use a Foley's catheter. Foley's bulb will be kept just above the internal os and inflated. That will cause lifting of the membranes and release of prostaglandins from the decidua. Okay, so that is what is most commonly used. Some centers use prostaglandin E2, otherwise called as dinoproston gel. Okay, but we do not use in our institute. We have not had good experience with it, so we have stopped using that. We use only physical method, that is Foley's this thing, and sometimes we use these hygroscopic agents, laminariatins kind of thing. The recent one which has come, we have used those things. That's it. Otherwise, pharmacologically, we don't use anything for cervical ripening. We use this, and then we use oxytocin for induction of labor. That's it. Okay. So those are the things about induction of labor. Now let's assume this patient went into spontaneous labor. Okay. So once she goes into spontaneous labor, it's 1 point in favor of a successful VBAC for us. Because I told you that we don't need to use any of these inducing agents or oxytocin and all this stuff. So we assume that labor will go on physiologically and her risk of having a repeat cesarean section or scar rupture is going to be much lesser. Okay. So you're in labor room monitoring patients along with your team of postgraduates, residents, whatever. Okay. And this patient is coming with labor pains, spontaneous labor pains. She was fully effaced 3 to 4 centimeters. Okay, the residents have seen her and they have done an ARM to help her augment the labor. Okay, then they will ask you to monitor the patient. What will be your aim of monitoring in this patient now is to diagnose her at the level of scar dehiscence. Okay, so let me just tell you what is scar dehiscence now. So basically, remember, there are going to be 3 layers at the level of the interface of the scar. There are going to be 3 layers. One is the myometrium itself. All of you know that there is myometrium over there. Okay, and then inside the myometrium, we have amniotic membrane, and outside the myometrium, towards in the abdominal cavity kind of thing, we'll have the UV fold of peritoneum. So these 3 layers are there. Okay, among these 3 layers, if the patient is going to have a scar problem, which one do you think will give way first?
The myometrium.
Myometrium. Good. Okay, because myometrium is not a continuous sheet of cells. Please remember. They are interlacing, with lot of gap in between, and the lower segment is not a dense, thickly populated with muscle cells. You know that it's a very passive thing, and the space is going to be much more over there. And it is one part of the 3 layers which is actually getting a shearing kind of effect during contractions. The upper segment will just retract and contract, and that will lead to a lot of pulling effect, shearing kind of effect on the scar. So the first layer to give way is myometrium. Remember that. When only myometrium gives way, we call it as scar dehiscence. That means the amniotic cavity membrane is intact and the pelvic peritoneum or UV fold of peritoneum is intact. Okay, otherwise called as cirrhosis. Okay, so when this particular thing happens, okay, the morbidity for the baby is going to be least. Okay, so before we go ahead about why morbidity is least, tell me, why do babies die in ruptured uterus? You know that fetal death is common once uterus completely ruptures. All of you know that. Why do you think these babies die?
Because the amniotic fluid is also like it starts leaking into the peritoneum, and
So?
then the cord entanglement is higher chance.
No, Thanusha. Anybody else? Shankar Narayanan, Priya?
The fetus does go out of the this one uterus also, ma'am.
Okay, so what happens?
Ruptured.
Hmm?
Decreased blood flow to the
Right.
fetus.
Obviously, when rupture uterus occurs, you know that baby is going to escape into the peritoneal cavity. Because uterus knows only one thing. Whenever there is an opening, whether it is cervical opening or the rent of whatever the rupture of the scar, it will only sense it as there is an opening and it is in labor. So it will contract and push the baby out. That's all. So once the baby goes into peritoneal cavity, why should the baby die?
The placental cord, the blood supply may be hindered.
See, answers are coming in the chat box over there. Basically, it is placental separation. Please remember that there is nothing to do with the amount of cord entanglement, nothing. It is essentially, moment the uterus empties, what does uterus do? Uterus contracts and retracts. Okay, when uterus, in labor, what happens is uterus will only contract. It won't have significant retraction over the, only towards the end of first stage and in second stage, some amount of retraction happens to push the baby down into the lower segment. Otherwise, throughout the labor, uterus is only contracting. What is contraction now? Myometrial fibers will shorten, okay? But then once it relaxes, they'll again elongate. That is contraction. Retraction is the irreversible shortening. They shorten and they won't go back to the original size. Okay, that is retraction. Okay, so what happens in normal labor is, once the baby is delivered, that means the uterus will sense it as loss of intrauterine volume. Okay, I'll give an example to you. Take for example, polyhydramnios. If there is sudden rupture of membranes in polyhydramnios, what happens? What's the complication there?
The
abruption. Okay, so abruption is a known complication. Why does abruption happen? Because uterus will sense it as loss of intrauterine volume. So that will start contracting and some amount of retraction also will take place. Whenever the uterus, the uterine myometrium contracts and retracts in the placental implantation site, what will happen? See, the uterus, the uterine wall is like this. Okay, placenta is attached like this. Can you see? I don't know. Yeah, this is better. This is placenta, like this hand. This is uterine wall. Okay, so once it contracts and retracts, you can see what's happening. There's going to be buckling of the placenta and separation of the placenta. Okay, so whether it is in polyhydramnios following sudden rupture of membranes where there is significant loss of intrauterine volume, or in rupture uterus where the baby escapes into peritoneal cavity either partially or fully, okay, or in normal labor, once baby delivers, uterus is going to do this only. It's going to contract and retract, and there's going to be buckling and placental separation. This is what kills the baby, because in normal labor, when this phenomena occurs, baby is already in an open environment where there is oxygen. It will take its first breath and it will live. But here the baby is escaped into a closed space where there is no oxygen, the abdominal cavity, right? So there is no way baby will get any kind of oxygen now, because the placenta is separated. So the umbilical cord and placenta and the oxygen trunk, everything is cut off for the baby. That is why babies die. Okay, we have had cases where mothers will be absolutely stable. Okay, no hypotension, no shock, nothing. Maybe slight tachycardia, which also settles off after some time. Okay, and they will just come with rupture uterus and baby in the peritoneal cavity. Okay, so it is not something like mother will go into shock and she'll go into hypotension. That's why baby dies. All those things are not at all correct. Okay, this is the exact phenomena what happens which leads to the fetal death. Is it clear? Okay, now let's go back to scar dehiscence. So when it is scar dehiscence, when the amniotic membrane is intact, it means that there is no loss of intrauterine volume. So there is no retraction of the myometrial fibers. So the baby is going to be absolutely fine in this stage. Okay, So once it ruptures, there's going to be either partial or complete extrusion of the baby outside the uterine cavity, which leads to some loss of intrauterine volume, and that will be perceived by the uterus and it will start contracting and retracting. Okay, which will lead to either partial or complete separation of the placenta, leading to varying degrees of hypoxia to the baby. By the time we rush to OT and deliver, we may have, depending on how much time it took, how fast the whole event occurred, because this is something which is extremely unpredictable. There is no way I can tell you, okay, now dehiscence is occurred, so it will take 20 minutes for it to become complete rupture. No, I can't tell that, because we have seen scar dehiscence in women where we do an elective cesarean section. Okay, they would have been living with scar dehiscence for days together also, without having any clinical signs. Okay, so it's very important to remember that in labor, if you suspect that the scar is looking bad, better to rush and do a cesarean section as early as possible. So what are the signs? What exactly will you look for when you want to monitor the patient, when you want to catch her at that stage? What all we should look for?
Her vitals, tachycardia, hypotension, which would have dropped, and then fetal heart.
Hypotension is not a sign of scar dehiscence. I'm telling you, I'm repeating to you again that we are not trying to diagnose rupture uterus where there is nothing much we can do. Our aim is to diagnose at the level of scar dehiscence. Okay, maternal tachycardia, yes, it is an indicator. The body will sense there's something wrong happening, and maternal tachycardia happens whenever there is scar dehiscence. Okay, so number one is maternal tachycardia. Then the number two is
fetal heart rate. There will be variations, ma'am. Initially, there will be tachycardia, then
varying fetal heart rate or fetal heart rate irregularities. Okay, then we discussed one of scar tenderness. Okay, that's called as scar tenderness, what you mentioned over here, right? Okay, so that is another important thing. Then one more is fresh bleeding per vagina. They can have fresh bleeding per vagina. Okay, so most important indicator among this, what do you think about the maternal tachycardia? You think it is good enough to suspect scar dehiscence? A patient comes, whatever patient I told you, fully effaced 3 to 4 centimeters, she's come into labor room and her heart rate is 120. Is it equal to scar dehiscence?
No, ma'am. We have to see other, like fetal heart rate also, and then if there's any scar tenderness.
Very good. Okay, the first thing what we do is, look for other signs of scar dehiscence. Look for fetal heart rate irregularities, look for scar tenderness. Okay, look for any fresh bleeding per vagina. None of them are there. Then you see whether this maternal tachycardia is due to the scar problems. Not that it can't be. Okay, please remember, not that all of them have to be there. Okay, even one sign can be an indicator of scar dehiscence. But when there is no other sign, fetal heart is going absolutely fine, then it is very important to see for other causes of tachycardia. Tachycardia is an extremely non-specific sign, right? There can be so many other causes. Patient may be very anxious, patient may be dehydrated, patient may be having fever, she may be having anemia. I'm just giving you some top 3-4 causes of maternal tachycardia. Okay, or she may be having some thyroid swelling, some heart ailment, whatever. Okay, so rule out other causes of maternal tachycardia if it is an isolated finding. Okay, if it is associated with some other finding like scar tenderness or fetal heart rate abnormality, then you know that it is due to scar itself. There is no need to break our head about whether it is due to something else. Okay, but if it is an isolated sign of scar dehiscence, then you better look for other causes of maternal tachycardia. Okay, it's a very non-specific sign. Okay, but same cannot be told about fetal heart rate irregularity. It's an extremely sensitive sign of scar dehiscence. Okay, if a patient with previous LSCS is in labor and is showing fetal heart rate irregularities, run to OT. Okay, it's a most sensitive indicator of scar dehiscence. That is why we do not give trial to any patient who's got a high risk factor of intrapartum fetal distress. For example, fetal growth restriction. Okay, severe preeclampsia, where we know that there is going to be some amount of placental insufficiency and we expect intrapartum fetal distress. Don't give trial of scar, because you will lose a very sensitive sign of scar dehiscence over there. Okay, you won't know whether it is due to growth restriction or due to scar death, will lead to unnecessary confusion. So whenever there is an X factor other than the previous LSCS where the fetal heart rate may be affected, better not to give trial of scar. Okay, that's it. And then fresh bleeding per vaginum, the important differential diagnosis is show. Okay, you know that in active labor, women will have show, but remember, show is going to be associated with lot of mucoid kind of discharge. Okay, and fresh bleeding is going to be just watery vaginal bleeding. Okay, it's only an additional sign. As you know, isolated signs, only fetal heart rate is important for us. I told you about scar dehiscence, scar tenderness, that it is in a patient who is in labor, a newly occurring scar tenderness is extremely important for us. If she's been having scar tenderness right from the ward, when she was not in labor, think of adhesions. If she is having some urinary symptoms, think of cystitis. Okay. But if the patient suddenly develops scar tenderness, you've been monitoring her in the labor, last time when you were palpated, nothing was there. Next time when you go, you find there is significant scar tenderness. Okay. Be very worried. That's a very important sign. Newly occurring scar tenderness intrapartum. Okay. Newly occurring maternal tachycardia or anytime fetal distress or fetal heart rate irregularities are very important signs of scar dehiscence. Am I clear? Okay. So this is how we will monitor the patient to diagnose at the level of scar dehiscence. If we are not able to diagnose at this particular level, then we will end up having problems, because I told you in labor, things can progress either very fast or you may not get enough time to save this particular baby. Okay. The next thing which can happen is incomplete scar rupture. In incomplete scar rupture, the next membrane which will give way is, we're left with two things now, amniotic membrane and UV photoperitoneum. Among them, which is the next one to give way? If you have to come in one particular order, the first thing to give way is myometrium. Second thing to give way is
the UV fold. Yeah.
That's the last thing to give way. Okay, amniotic membrane gives way next. Okay, so once amniotic membrane gives way, what happens? Baby parts can get into the broad ligament leaves and all this stuff now. Even though your UV fold is still intact, there may be escape of the amniotic fluid into the leaves of broad ligament. The limb of the baby may escape outside the uterine cavity. There's going to be some loss of intrauterine volume over there, right? So what happens in normal labor is the head will fix onto the pelvic brim and there's not going to be much loss of hindwaters. Okay, but when there is a rent in the uterus, okay, even though it is not communicating with the peritoneal cavity, the fluid can easily escape into the leaves of broad ligament. Okay, there's going to be some loss of intrauterine volume, which may lead to some partial separation of placenta. So there, the morbidity for the baby is going to be higher in this level. Okay, but we'll never know when this particular thing will happen. The added sign in this particular level is a bulge in the suprapubic area, which is not relieved on catheterization. Okay, there appears a bulge in the just above pubic symphysis. Okay, you think it will look like a bladder, full bladder. You put in a catheter, bladder is empty. Be very worried. This is an incomplete scar rupture, which may rupture any moment now. So you have to run to OT now. Now this is going to be like literally, what's his name? Usain Bolt kind of speed you have to run to OT now, because the time is very, very less with you. Okay. So the next thing which happens is a complete scar rupture, which we don't want to see in labor. Okay. We have to diagnose it at the level of scar dehiscence, maximum at the level of incomplete scar rupture. Okay, if your OT is next door, you can save babies even in incomplete scar rupture, but it's always better to diagnose the level of scar dehiscence. Complete scar rupture can be dangerous both for the mother and for the fetus. Obviously for the fetus, because I told you it will escape into the peritoneal cavity and it will lose its life. Okay, or come out extremely asphyxiated. If it survives, it is going to be a vegetable for you. Okay, so it's better that we should not go to that particular level at all. Okay. So incomplete scar rupture, what are the signs can be
there? Same, like maternal vitals, and then fetal heart sound might be absent. Then the fetal parts can be felt easily and superficially. Suprapubic bulge is present.
See, all those things will disappear now. Okay, all your scar tenderness, bulge, all those things are not going to be there. Rupture uterus, number one is if it is involving the uterine vessels. Yeah, if it's involving the uterine vessels, it will lead to maternal shock kind of feature. Okay, if it is not involving the uterine vessels, there is no significant maternal blood loss, then mother will just have tachycardia and she will tell you that I was having intermittent pains till now. Now I'm not getting any pains. That is cessation of contractions. Because uterus is completely ruptured, it will contract completely and go and lie in one side. Baby will be lying in the peritoneal cavity. Okay, that is number one history you will get. Okay, and When you examine, you will find tachycardia, hypotension depending on the amount of blood loss. Okay, the per abdomen and pallor also depending on the amount of blood loss. Please don't forget the pallor part. Okay, when you examine the abdomen, there will be loss of uterine contour. See, when you see a pregnant woman's, when you feel the pregnant woman's abdomen, you know that baby is contained in one more bag inside the abdominal cavity. Understood? Okay, it is like an ovarian cyst and ascites. In ascites, you know that fluid is there in the abdominal cavity. Okay, but in ovarian cyst, you can appreciate that there is fluid in one more bag inside the abdominal cavity. Similarly, in an intact uterus, baby is going to be in another bag inside the uterine cavity. In rupture uterus, it's going to be in the abdominal cavity. Okay, so the loss of uterine contour, the piriform shape of the uterus will be lost. Okay, number one. Number two, fetal parts will be felt much superficially, as you told. Okay, fetal heart will be absent. Okay, these are the three important signs per abdomen. Okay, in PV, what signs will be?
Per vagina, fresh, bright blood per vagina.
Have fresh vaginal bleeding. Okay.
And then loss of station.
Maybe loss of station. What do you mean by loss of station?
Usually when it's engaged, if there's a rupture uterus, then incomplete rupture uterus, then it goes back it won't be at zero station on the ischial spine level. It goes back.
Okay. Basically, see, when the baby escapes into peritoneal cavity, why will it still be in the pelvis? No, the head will recede back. Okay, that's what is loss of station. Clinically, how do we assess it is the cervix, which was well applied to the presenting part, will start loosely hanging now. Okay, and there will be receding of the presenting part, which is called as loss of station. And most important thing for us is fresh vaginal bleeding over time. Okay, these are the signs which are which we appreciate in the pelvic examination. Okay, so this is rupture uterus, which we do not want to see in labor room. I'm telling you again because you know that it can be catastrophic, especially in case of previous LSCS. If it's involving uterine vessels, mother also will suffer with hemorrhage. Okay, and if it is somewhere near the bladder, when the rupture extends into the bladder, they can have bladder injury. Okay, and when you are suturing, you may not be able to suture because of a ragged edges, which is very much unlikely in post-cesarean cases. We'll usually end up doing a rent repair and all this stuff. But most important thing is the fetal loss in case of rupture uterus. Okay, so it's very important to make sure that you don't have this problem. Stop sharing, Priya. I'll just show you one picture. I told you about different levels of your, how uterus ruptures in case of previous LSCS. Okay, but when we do a cesarean section, we may not really see it like this. Okay, what we'll see is, I'll see whether it is still open. Where is the picture? Yeah, give me a moment. This is one of my postgraduates who wrote this for me. So this is called as Qureshing. Can you see the screen, Thanusha?
Yes, ma'am.
Okay. So this is called as Qureshi's grading of the uterine scar. Okay, this is an objective way of grading the uterine scar. Basically, they grade it as grade 1, grade 2, grade 3, grade 4. Okay, so grade 1 is when it is absolutely normal, like it doesn't even look like a scar. You may just see some fibrosis, but it will be normal thickness. It's a well-developed lower segment. That's all. Grade 2 is lower segment has become thin, but the intrauterine contents are not visible to your naked eye. Okay, grade 3 is the scar area has become translucent. And can you see the black hair of the baby being seen here? Moment you open the abdomen, you will see this lower segment is papery thin and the contents are visible. Okay, and then the grade 4 is there is a defect and you can see the defect very clearly. That is your scar dehiscence. If you have to open the UV fold of peritoneum and then you see the defect, it is scar dehiscence. Okay, and the amniotic membrane is intact. Okay, but if as soon as you open, you find that UV fold of peritoneum also is given where everything is given where it is rupture uterus over there. Okay, but UV fold of peritoneum is the last thing to give most of the times. There are always exceptions to rules. Okay, but what's important is usually this is the order of events. The first thing to give is myometrium and then the amniotic membrane and then the peritoneum. Okay, so when you do a cesarean section, When you open the abdomen, you put in the Doyen's retractor. You've seen the Doyen's, this is a Doyen's retractor here. This is typically used in cesarean section. Moment you put this in, you'll be seeing the lower segment. Okay. So how do you identify the lower segment?
The loose peritoneal fold is attached to it. Once
Peritoneal fold is attached loosely to the underlying myometrium here. You can pick it up using a thumb forceps. You take a tooth forceps, you will try to lift it, you'll be able to lift it up. Okay, the peritoneum is loosely attached to the underlying myometrium here. Okay, but in case of upper segment, you can never pick the peritoneum. It will be densely adherent to the underlying myometrium, the serosa of the, or which becomes a serosa of the organ itself. Okay, so you will identify the UV fold like this, and then you open it. As soon as you open, you see the amniotic membrane. There is no myometrium, it is scar dehiscence. As soon as you open, you see the fetus directly, then it is incomplete scar rupture. When you open the abdomen, you find that, part of the baby is lying in the peritoneal cavity, everything is open, it is complete scar rupture. But before that, this is a grading where you're not able to tell whether it is peritoneum thinned out or whatever. All the three layers will become a single layer here. So we grade these scars. This is how we see. Okay, normal. Okay, grade 1. It's thinned out, but the contents are not visible. This one is translucent or papery thin. This is basically for us to, see whether our decision for cesarean section in view of a doubtful scar was justified. That's all. This is how we grade the uterine scar. Okay. I'll stop sharing now. Any doubts? Who's moderating? Priya? Are there any doubts in the chat box?
No, ma'am. There's no doubts here. I'll just check on you.
Yeah. Any doubts to people who are attending here? Chat box, nothing is there. Only answers are there. Good.
I had a doubt. Like you explained scar dehiscence and then scar rupture, incomplete, complete. So based on the grading, the scar rupture will be an intraoperative diagnosis, whether it's complete or incomplete.
Obviously, it's all intraoperative diagnosis. We can only suspect that the scar is not behaving itself. That's it. Okay. When we're monitoring intrapartum, we can only suspect that the scar is giving way. That's all. Okay. We'll say suspected scar dehiscence. The indication for cesarean section will be suspected scar dehiscence. Once you go to OT, you see that it is really given with, then only your diagnosis will be scar dehiscence. Okay. So that is how it goes. There's a question here. In ultrasound thickness, at which value we really don't use the ultrasound thickness. They say anything less than 4 millimeter is dangerous to give scar. 3 millimeter and below is dangerous. But we generally do not use that particular thing. Some units use here, but I do not use. Okay, it's not very simple to do. There's a lot of inter-observer variation in this particular finding. Okay, so I generally do not use that. I go by patient's consent and historical contraindications for trial of scar by a previous obstetric history and current examination of the patient. If the baby is looking too big now, like more than 3.7 kg, we don't give trial of scar. If there is any doubt in the pelvis, we don't give trial of scar. Basic idea is that the whole program will collapse if you have too many rupture uterus, right? So we'll try to select the patients to, very carefully so that we don't end up having too many rupture uterus if we induce them. Okay, or allow them for spontaneous progressive labor. Okay,